I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. So, I'm almost 49, therefore with impeccable timing for this particular series, over the next 8 episodes we're talking about menopausal hormone therapy, or MHT, previously called HRT, or hormone replacement therapy. The terminology changed because the word replacement can be misleading. It suggests that menopause is a deficiency disease and that treatment replaces every hormone to the levels someone had during their reproductive years. And that's not what we're doing. Natural menopause is a normal biological transition, and MHT generally uses selected hormones at individualized doses to treat troublesome symptoms and provide particular benefits. So menopausal hormone therapy more accurately describes the treatment without suggesting that we are trying to recreate a pre-menopausal hormone state. But before we get anywhere near patches, gels, capsules, progesterone, testosterone, risks, benefits, or prescribing choices, we need to understand what menopause is. Because menopause is sometimes discussed as though one day your ovaries simply clock off, your estrogen disappears, and your period stops. And that's that. But biologically, it is usually much messier. For many people, the difficult part is not a smooth, steady decline in hormones, it's the unpredictability of the transition. Hormones rising, falling, and occasionally behaving as though they've been left in the hands of a toddler at a control panel. That transition is called perimenopause, and understanding it helps explain why someone can have a normal period 1 month, miss the next one, bleed heavily the month after that, wake drenched in sweat, feel unusually anxious, forget the name of a colleague they'd worked with for 10 years, and still be told that their hormone blood test is normal. So in this episode, we're going back to physiology. What are the ovaries doing? What are the brain and pituitary gland doing? What happens to estrogen, progesterone, follicle-stimulating hormone, and ovulation? And why can all of this produce such a wide and inconsistent collection of symptoms? So what do we mean by menopause? Well, first, some terminology. Menopause is not the whole transition. Strictly speaking, menopause is a point in time, the final menstrual period. But we can only identify it retrospectively once someone has had 12 consecutive months without a period, assuming there's no other cause for the absent bleeding. The years leading up to that final period are usually called the menopausal transition or perimenopause. After menopause comes postmenopause. In ordinary conversation, people use menopause to describe the entire experience, and that is completely understandable. But clinically, separating the transition from the final menstrual period matters because hormone patterns, bleeding, contraception needs, and treatment choices can differ. Natural menopause most commonly occurs between the ages of 45 and 55, although there is a considerable variation. Menopause occurring before 45 is described as early menopause. Before 40, we use the term premature ovarian insufficiency, or POI. That is not simply an earlier version of the usual transition. It has distinct implications for fertility, bone health, cardiovascular health, and hormone replacement, and it deserves its own careful assessment. Menopause can also be induced. Removal of both ovaries causes surgical menopause, usually with a much more abrupt fall in ovarian hormones than natural menopause. Chemotherapy, radiotherapy, and some medicines can also impair ovarian function temporarily or permanently. So when we talk about what the hormones are doing, we need to remember that the pattern depends on why menopause is occurring. Let's go back to a typical menstrual cycle. The ovaries do not operate independently. They are part of a feedback system called the hypothalamic pituitary ovarian axis. The hypothalamus in the brain releases gonadotrophin releasing hormone, usually shortened to GnRH. GnRH signals the pituitary gland to release follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. FSH helps recruit and develop ovarian follicles. Each follicle contains an immature egg. As follicles develop, they produce estradiol, the main circulating estrogen during the reproductive years. Rising estradiol helps build the endometrium, the lining of the uterus, in preparation for a possible pregnancy. At the right point in the cycle, sustained higher estradiol contributes to an LH surge, which triggers ovulation, the release of an egg from the dominant follicle. After ovulation, the emptied follicle becomes the corpus luteum. The corpus luteum produces progesterone along with some estrogen. Progesterone stabilizes and transforms the endometrium so that it can support implantation. If pregnancy does not occur, the corpus luteum breaks down. Progesterone and estrogen fall, the endometrial lining sheds, and a menstrual period begins. That's the simplified textbook version. Of course, real cycles are not perfectly identical even before perimenopause. But for much of reproductive life, the system is usually coordinated enough to create reasonably predictable ovulation and bleeding. So what begins to change? As the ovaries age, the number and responsiveness of the remaining follicles decline, and this is sometimes described as declining ovarian reserve. One of the earlier hormonal changes is a reduction in inhibin B, a hormone produced by developing ovarian follicles. Inhibin B normally helps suppress FSH. As inhibin B falls, that restraint weakens, so the pituitary produces more FSH in an attempt to stimulate the ovaries. You can think of the pituitary as turning up the volume because the ovaries are becoming harder to reach. Sometimes the ovaries respond, sometimes they respond late, sometimes a follicle develops but ovulation does not occur, sometimes estradiol production is low, and sometimes, importantly, estradiol rises very high. And this is why the phrase estrogen deficiency does not fully describe early menopause. Later, particularly after the final menstrual period, consistently lower estrogen becomes central. But during perimenopause, fluctuation is as important as absolute deficiency. Estradiol may swing markedly from one week to another. FSH can also vary. A blood test, therefore, only captures one moment in a moving system. FSH may be elevated one day and less remarkable on another. Estradiol may be low, normal, or high, depending on when the sample is taken and what the ovaries happen to be doing. This is why, for most otherwise healthy people aged over 45 with typical symptoms and cycle changes, perimenopause is diagnosed clinically rather than through a single hormone blood test. Testing can still be useful in selected situations. For example, suspected premature ovarian insufficiency, unusual symptoms, uncertainty about the diagnosis, or the need to investigate another condition. But a normal FSH does not automatically rule out perimenopause. And a single high FSH does not necessarily tell us exactly where someone is in the transition. The the Australian Menopause Society advises that FSH, estradiol, progesterone, and AMH tests are generally unnecessary for diagnosing menopause in women over 45 with a typical clinical presentation because hormone levels can fluctuate significantly. Progesterone is part of this story too. Progesterone is produced in meaningful amounts after ovulation. As ovulation becomes less consistent, progesterone exposure also becomes less consistent. Someone may still be producing plenty of estradiol, but if they do not ovulate during that cycle, they will not produce the usual luteal phase progesterone. This can contribute to cycle disruption and unpredictable bleeding. The endometrium may become exposed to estrogen without the same regular progesterone signal that would normally organize and stabilize it. The result can be delayed periods, skipped periods, prolonged bleeding, or unexpectedly heavy bleeding. But, and this is important, we should not automatically label every bleeding change as perimenopause. Heavy, prolonged, frequent, or otherwise abnormal bleeding may require assessment for pregnancy, fibroids, polyps, adenomyosis, thyroid disease, bleeding disorders, medication effects, endometrial hyperplasia, or cancer, depending on the individual situation. Bleeding after menopause, meaning bleeding after 12 months without a period, should be medically assessed. Perimenopause is common. It should not become an excuse to ignore red flags. Why do hot flushes happen? So, what symptoms can changing ovarian hormones produce? The best recognised are vasomotor symptoms, hot flushes and night sweats. A hot flush is not simply feeling a bit warm. It's usually a sudden wave of heat, often affecting the face, neck and chest. It can be accompanied by sweating, flushing, palpitations, anxiety, or chills afterwards. At night, the same process can cause sweats that wake someone repeatedly or soak their clothing and bedding. The precise biology is complex, but falling and fluctuating estrogen affects temperature regulation in the hypothalamus, the body's thermonuclear zone, the comfortable range within which it does not need to sweat or shiver, becomes narrower. A small change in core temperature that would previously have caused no response may now trigger vasodilation and sweating. In other words, the thermostat becomes unusually twitchy. This also helps explain why hot flushes can be triggered by heat, alcohol, stress, spicy foods, or a warm room, although triggers vary. And avoiding every possible trigger is not a substitute for treating significant symptoms. Sleep, mood, and brain fog. Sleep disturbance is another major issue. Sometimes sleep is disrupted directly by night sweats, but not every sleep problem in perimenopause is simply a hot flush in disguise. People may have trouble falling asleep, wake repeatedly, or wake very early. Mood changes can also occur, including irritability, anxiety, low mood, and feeling less emotionally resilient. That does not mean that every new mental health symptom is just hormones. Depression and anxiety still require proper assessment and treatment. Life at this stage may also involve work pressure, caring for children, caring for aging parents, relationship changes, illness, grief, and chronic sleep deprivation. But hormonal fluctuation may increase vulnerability, particularly in people with a previous history of hormone-sensitive mood symptoms, premenstrual dysphoric disorder, postnatal depression, or previous depression. Estrogen receptors are widely distributed through the brain, including areas involving in mood regulation, although the exact relationship between hormonal fluctuation and individual mood symptoms remains complex. Then there is cognition, the famous brain fog. People commonly describe difficulty concentrating, losing words, forgetting why they entered a room, or feeling slower at retrieving information. This can be frightening, especially when someone is working in a demanding role and has always relied on their memory. Sleep loss, anxiety, stress, and mood can all contribute. Hormonal changes contribute too. But progressive, severe, or unusual cognitive symptoms should not automatically be attributed to menopause without assessment. Again, menopause is common. In fact, it will affect 50% of the population if they live long enough, but it does not make every symptom benign. Vaginal, vulval, and urinary symptoms. Changes can occur in the vulva, vagina, bladder, and urinary tract. As estrogen levels remain lower, tissues become thinner, drier, less elastic, and more vulnerable to irritation. Symptoms may include vaginal dryness, burning, itching, pain with penetration, urinary urgency, recurrent urinary tract infections, or discomfort with urination. Collectively, these changes are called the genitourinary syndrome of menopause, or GSM. Unlike some vasomotor symptoms, which may improve over time, genitourinary symptoms often persist or progress without treatment. Lower urinary tract symptoms may include urgency, frequency, recurrent urinary tract infections, and waking repeatedly during the night to pass urine. That matters particularly in older women. Nocturia means getting out of bed whilst sleepy, in the dark, and sometimes in a hurry. Research suggests that nocturia is associated with around a 20% higher risk of falls in older adults. A fall can lead to a hip fracture, and for a frail older person, a hip fracture can begin a serious cascade of hospitalization, immobility, infection, loss of independence, and increased mortality. GSM is not merely an inconvenience. Untreated urinary symptoms can contribute to sleep disruption, falls, recurrent infections, and substantial loss of health and independence. Sexual well-being can also be affected. Pain, dryness, fatigue, poor sleep, mood, relationship factors, medicines, health conditions, body image, and changing androgen levels can all influence sexual function. Low desire is not always caused by a single missing hormone, and it is not solved simply by telling someone to relax or schedule a date night. It deserves the same respectful, multidimensional assessment as any other health concern. What about joints, weight, and palpitations? Muscle and joint aches are also frequently reported. Some people notice headaches or changes in their migraine pattern. Breast tenderness may occur, particularly when estrogen is fluctuating rather than consistently low. Skin may become drier. Hair patterns may change. Some people notice palpitations. Body composition commonly shifts with age and menopause, with a tendency towards reduced lean muscle mass and increased central fat. But that is influenced by aging, activity, sleep, diet, genetics, and many other factors, not simply a broken metabolism caused by one hormone. The key point is that there is no single universal menopause experience. Some people have almost no symptoms beyond their periods eventually stopping. Others have symptoms that substantially affect work, relationships, exercise, sleep, and quality of life. Symptoms do not always start with irregular periods, and they do not arrive in a nice, neat package. Someone may have night sweats without mood symptoms. Someone else may have severe cycle-related anxiety and heavy bleeding, but no hot flushes. And another person may reach postmenopause feeling relatively well and develop vaginal or urinary symptoms years later. This variability is one reason people can feel dismissed. If their experience does not match the stereotype of a woman in her 50s fanning herself, they may not recognize it as perimenopause, and neither may their clinician. But not everything is menopause. We also need to avoid the opposite problem, turning perimenopause into an explanation for absolutely everything that happens between 40 and 60. Fatigue could relate to sleep disruption, but it could also be caused by iron deficiency, thyroid disease, depression, sleep apnea, or another medical condition. Palpitations may occur during hot flushes, but they may also require cardiac assessment. Heavy bleeding may cause iron deficiency and anemia. New headaches, neurological symptoms, significant unexplained weight loss, persistent abdominal symptoms, a breast lump, postmenopausal bleeding, or severe mood symptoms all deserve appropriate investigation. Good menopause care is not about choosing between is it hormones and is it all in your head. It's about recognizing the hormonal transition while still practicing proper medicine. Can you still become pregnant? Another important point, perimenopause does not mean pregnancy is impossible. Ovulation may be less predictable, but it can still occur. And MHT is not contraception. Someone who needs pregnancy prevention may still require contraception during the transition. The best option depends on age, bleeding, symptoms, medical history, and individual preferences. And we will return to this when we discuss how MHT fits alongside contraceptive pills, progesterone-only methods, and hormonal intrauterine devices. So where does MHT fit into all of this? At its simplest, menopausal hormone therapy uses estrogen with a progesterone where required to treat symptoms associated with the menopausal transition and menopause. If a person has a uterus and requires systemic estrogen, endometrial protection with an appropriate progesterone is required. If the uterus has been removed, estrogen may be used without a progesterone, although there are exceptions and individual considerations. Local vaginal estrogen is a different therapeutic category from systemic MHT and is used mainly for genitourinary symptoms. MHT is the most effective treatment available for menopausal hot flushes and night sweats, and estrogen also prevents the bone loss associated with menopause and lowers cardiovascular and dementia risk. But the form, dose, and route and combination matter. A patch is not pharmacologically identical to a tablet. Micronized progesterone is not identical to every synthetic progesterone. A hormonal intrauterine device may provide endometrial protection in some regimens. And testosterone is not a general-purpose solution for fatigue, weight gain, or brain fog. We are going to unpack all of these across the series. We will look at who may benefit from MHT, when it can be started, whether someone needs to wait for their periods to stop, and how to choose between oral and transdermal estrogen. We will discuss progesterone and progestogens, including why they are necessary, what they do, and why tolerability can differ. We will examine breast cancer, blood clots, stroke, cardiovascular disease, bone health, and the way risk is influenced by age, timing, route, dose, and individual history. We will discuss the levonorgestrel intrauterine device, vaginal estrogen, testosterone, compounded bioidentical hormones, monitoring, and what to do when the first regimen doesn't work. And throughout the series, we are going to separate 3 different questions that are too often blended together. Does a treatment relieve symptoms? Does it provide long-term health benefits? And what risks does it carry for this particular person? Those are related questions, but they are not the same question. MHT should not be presented as either a dangerous relic that no one should use or a magical anti-aging treatment that everyone needs. It's a group of medicines, and like all medicines, it has indications, contraindications, benefits, adverse effects, uncertainties, and individual trade-offs. The right decision depends on the person in front of us, their symptoms, their age, their time since menopause, whether they have a uterus, their bleeding pattern, their contraceptive needs, their medical history, their family history, and importantly, their own preferences and priorities. So what have we learned? Perimenopause is not simply a slow, steady decline in estrogen. It is a transition marked by hormonal fluctuation, increasingly unpredictable ovulation, changing progesterone exposure, and, eventually, a more sustained fall in ovarian hormone production. That helps explain why symptoms can be so varied and why no two people experience the transition in exactly the same way. It also explains why a single hormone test does not rule out perimenopause in someone with a typical clinical picture. And while some symptoms are familiar, hot flushes, night sweats, sleep disruption, and cycle changes, others are still too often minimized. Genitourinary syndrome of menopause is one of them. It's not just vaginal dryness. It can include urinary frequency, urinary urgency, recurrent urinary tract infections, and nocturia. And in an older woman, repeatedly getting out of bed at night while sleepy and in a hurry can contribute to falls, fractures, loss of independence, and serious downstream harm. So these symptoms deserve to be asked about, recognized, and treated. But this leads us to an important question. Which of these symptoms can menopausal hormone therapy actually improve? Which symptoms might improve indirectly because sleep or hot flushes improve? And which symptoms are too often blamed on menopause when MHT is unlikely to fix them at all? That's where we're going next. Here are some reflective questions to drive your practice. How confident are you in explaining the difference between perimenopause, menopause, and postmenopause to a patient? How would you explain why a single normal FSH or estradiol result does not exclude perimenopause in someone over 45 with a typical clinical presentation? When a patient presents with symptoms such as fatigue, palpitations, heavy bleeding, or cognitive changes, what other causes would you consider before attributing them solely to menopause? Do you routinely ask patients about genitourinary symptoms such as vaginal dryness, urinary urgency, recurrent urinary tract infections, and nocturia? If not, how could you incorporate these questions into your practice? In episode 2, we will look at what MHT can and cannot treat. Understanding the hormonal transition is only the beginning. The next step is knowing what the treatment can realistically do.